Hi, this is Kathy. The following slides are on the topic of anxiety. Anxiety is an actual nursing diagnosis. Nanda defines anxiety as a vague, uneasy feeling of discomfort or dread accompanied by an autonomic response, with the source often nonspecific or unknown. Anxiety is a feeling of apprehension, uneasiness, uncertainty, or dread resulting from a real or perceived threat whose actual source is unknown or unrecognized. This is in contrast to fear, which is a reaction to a specific danger. Anxiety and fear have similar psychological symptoms. Anxiety, however, invades the central core of the personality and erodes self-esteem. Etiologies, or the causes of anxiety, can be related to uncertainty about, lack of control over, difficulty coping with, perceived threat to health of, lack of information about. This would be the second part in a three-part diagnostic statement. Fear and anxiety are part of life. For example, feeling anxious before you take a test or walking down a dark street is normal. This kind of anxiety is useful. It can make you more alert or even more careful. It usually ends soon after you are out of the situation that caused it. But for millions of people in the United States, the anxiety does not go away and gets worse over time. People may experience chest pains or nightmares. They may even be afraid to leave home. These people have anxiety disorders. Types of disorders include panic disorders, obsessive-compulsive disorders, post-traumatic stress syndrome disorders, and phobias, as well as generalized anxiety disorders. Anxiety is further categorized in degree of severity. Mild levels to anxiety, to moderate, to severe, or panic. Look at the different symptoms and characteristics of each. Generalized anxiety disorder is characterized by chronic anxiety and exaggerated worry and tension, even when there is nothing to provoke it. People with generalized anxiety disorder can't seem to shake their concerns. Their worries are accompanied by physical symptoms, especially fatigue, headaches, muscle tension, muscle aches, difficulty swallowing, trembling, twitching, irritability, sweating, and hot flashes. Treatments may include seeing a psychotherapist for cognitive behavior therapy and/or behavioral therapy. Medications are used for those who are open to using medication if it is needed. Panic disorder is an anxiety disorder and is characterized by unexpected and repeated episodes of intense fear accompanied by physical symptoms that may include chest pain, heart palpitations, shortness of breath, dizziness, or abdominal distress. People with panic disorder have feelings of terror that strike suddenly and repeatedly with no warning. During a panic attack, most likely the heart will pound, and the person may feel sweaty, weak, faint, or dizzy. Hands may tingle or feel numb, and the individual might feel flushed or chilled. Nausea, chest pain, or smothering sensations, a sense of unreality, or fear of impending doom or loss of control is common. Treatment may include cognitive behavior therapy, and for those who are open to using medication if it is needed. Phobias, particularly social phobia or social anxiety disorder, is an anxiety disorder characterized by overwhelming anxiety and excessive self-consciousness in everyday social situations. Social phobia can be limited to only one type of situation, such as fear of speaking in formal or informal situations, or eating or drinking in front of others, or it is very common. Most severe form may be so broad that a person experiences symptoms almost any time that they are around other people. People with social phobia have a persistent, intense, and chronic fear of being watched and judged by others, and being embarrassed or humiliated by their own actions. Their fear may be so severe that it interferes with work or school and other ordinary activities. Physical symptoms often accompany the intense anxiety of social phobia and include blushing, profuse sweating, trembling, nausea, and difficulty talking. Obsessive-compulsive disorder, or OCD, is an anxiety disorder and is characterized by recurrent, unwanted thoughts or obsessions and/or repetitive behaviors called compulsions. Repetitive behaviors such as hand-washing, counting, checking, or cleaning are often performed with the hope that preventing obsessive thoughts or making them go away. Performing these so-called rituals, however, provides only temporary relief, and not performing them markedly increases anxiety. People with OCD may be plagued by persistent, unwelcome thoughts or images, or by the urgent need to engage in certain rituals. They may be obsessed with germs or dirt, and wash their hands over and over. They may be filled with doubt and feel the need to check things repeatedly. Post-traumatic stress disorder is an anxiety disorder that can develop after exposure to a terrifying event or ordeal in which grave physical harm occurred or was threatened. Traumatic events that may trigger post-traumatic stress disorder include violent personal assaults, natural or human-caused disasters, accidents, or military combat. People with post-traumatic stress disorders have persistent frightening thoughts and memories of the ordeal and feel emotionally numb, especially with people they were once close to. They may experience sleep problems, feel detached or numb, or be easily startled. The main treatments for people with post-traumatic stress disorder are psychotherapy, also known as talk therapy, or medications can be used, or most likely both. Everyone is different, so a treatment that works for one person may not work for another. It is important for a person experiencing post-traumatic stress syndrome to be treated by a mental health care provider who is experienced with this disorder. Some people with PTSD need to try different treatments to find out what works for their symptoms. If someone with PTSD is going through an ongoing trauma, such as being in an abusive relationship, both of the problems need to be treated. Other ongoing problems can include panic disorder, depression, substance abuse, and feeling suicidal. Please be familiar with the classification of medications related to anxiety. Also remember that once you start on a medication, it is important not to stop taking it abruptly. Certain drugs must be tapered off under the supervision of a physician, or bad reactions can occur. Make sure the client talks to the healthcare provider who prescribed the medication before they decide to stop taking it. For trouble with side effects, it's possible they can be eliminated by adjusting how much medication they are taking and when it's being taken. Anxiolytics are drugs used to treat anxiety disorders. There are benzodiazepines and non-benzodiazepines. Benzodiazepines with brand names such as Ativan, Centrex, Valium, Xanax are used to treat panic disorders and generalized anxiety disorders as well as social phobias. They are extremely habit-forming, and long-term use is not recommended because it can lead to dependence and withdrawal reactions when stopped. Non-benzodiazepines is a new classification of drugs on the market that you see advertised on TV. First, all of these drugs have a relatively short half-life, so there is little problem with the accumulation of drug in the body or with waking up feeling groggy in the morning. Secondly, while both barbiturates and benzodiazepines have a direct effect upon the stages of sleep while taking them, these new drugs do not. Previously denied all important deep sleep and REM dream stages of the sleep cycle, these new drugs do not upset this cycle. Third, it is claimed that these drugs are less likely to be addictive. Both benzodiazepines and non-benzodiazepines enhance the effects of the body's natural tranquilizer GABA, or GABA. One problem with benzodiazepines, however, is that they are not selective in the receptor sites that they target within your brain. Targeting not only these areas of your brain you wish to shut down for sleep, but also shutting down areas you need while awake. These new non-benzodiazepine drugs with a different chemical structure are reputedly far more selective in the receptor cells that they target. Common interventions for mild to moderate anxiety is talking about it, helping a client identify what their anxiety is, encouraging them to communicate, encouraging to do their own problem solving, and helping them to explore the areas that is causing them anxiety. Interventions for severe to panic anxiety include just remaining with the client, maintain calmness, speak slowly, quietly, and stay calm yourself. Defenses are mechanisms that people use to protect themselves from painful awareness of feelings and memories. Using these defenses help people lower their anxiety. Your textbook also identifies a multitude of defense mechanisms. Be able to recognize defense mechanisms in a case scenario or case study, in addition to being able to provide examples of each. Explore the website in the link on this slide. On the left-hand side are the most common defense mechanisms. When you enter this website, explore it, and then you will be finished with the slides on coping and anxiety. The following slides cover interventions and prevention of complications. Complications occurring postpartum include hemorrhage, thrombosis, infection, and depression. Collaborative problems are those problems which the nurse consults with the physician. Postpartum hemorrhage is common. It used to be the leading cause of maternal deaths. Early hemorrhage, occurring within the first 24 hours, is generally caused by uterine atony, the uterus that does not clamp up, or trauma to the birth canal, lacerations and hematomas. Late hemorrhage, occurring a week to 2 weeks following the birth, oftentimes is caused by subinvolution, again that uterus that does not reduce in size, and retained placental fragments, which continue to cause bleeding. Interventions for hemorrhage include fundal massage and its attempts to firm up the uterus. Pitocin, which is the same drug used in labor delivery to start labor, will also contract the uterus so that it will reduce bleeding. Methadone is a medication given, usually IM, because an IV is not in for Pitocin. It's a medication that acts very quickly. You cannot give it if a mother has hypertension because it will increase the blood pressure very rapidly, but it will reduce the amount of hemorrhage. Hemabate is also another drug that it's used that will reduce the amount of bleeding by contracting the uterus very quickly. Please know these drugs and know the side effects of them. Thrombosis is a complication of postpartum due to the hypercoagulation of the blood and the changing of clotting factors postpartum. Common disorders include the superficial vein thrombosis, deep vein thrombosis, and pulmonary embolism. With superficial and deep vein thrombosis, the signs and symptoms are redness, swelling, warmth, and tenderness. With pulmonary embolism, the mother will have chest pain as well as difficulty breathing. Interventions to prevent thrombus formation is ambulation. Women should not be lying around in bed. TEDs and support stockings will also help. If thrombus formation does occur, treatment then is bed rest with a gradual increase in activity and heparin. Infections may occur postpartum due to tissue trauma or prolonged rupture of membranes. There are basically 4 types of infections that can occur: the metritis, the wound infections, urinary tract infections, and mastitis. Metritis is infection of the uterus. Its signs and symptoms include fever, chills, very much the flu-like symptoms, malaise, anorexia, abdominal pain, and also the key indicator would be the foul-smelling lochia. The signs of infection would be the increased temperature, again the foul-smelling lochia, and increased white blood cell count. Common sites of infection can also be wound infections due to C-section, also perineum, lacerations. This slide also indicates to remember the Rita scale when you are assessing. Urinary tract infections can occur due to possibly an insertion of a catheter during labor or a hypotonic bladder. Signs and symptoms of UTIs are dysuria, urgency, frequency, a low-grade fever, and chills, oftentimes later with flank pain if it's kidney involvement. Mastitis is the infection of the breast. The common organism is Staph aureus, which generally enters through a fissure in the nipple. Signs and symptoms are initially flu-like symptoms with fatigue and body aches, fever, chills, malaise. It's characterized by local area of redness and inflammation, generally on one breast. Management is antibiotics and milk expression. Remember, the milk is not infected. The baby can still go to breast. But the important thing is that the milk should be expressed so that it doesn't continue to build up and cause further discomfort. Unfortunately, postpartum depression is common. It usually develops within the first 3 months and may occur any time during the first year. We do not know what causes it. Risk factors include hormonal fluctuation, history of depression, and mental illness. Women with postpartum depression have a 50% chance of getting it after subsequent pregnancies and may be at increased risk for future depression not associated with pregnancy. Signs and symptoms include a lack of interest in surroundings, lack of interest in caring for the baby, difficulty concentrating, weight changes, lack of appetite. It does have a tremendous impact on the rest of the family. Treatment includes talk therapy with a psychotherapist or social worker and sometimes antidepressants. This concludes the slides covering postpartum complications. The following slides review the assessment of the postpartum woman. The 2 acronyms typically used to remember the postpartum assessment are the bubble HEP and the 12-point check. It doesn't matter which one you use as long as you assess your client in an organized manner. The bubble HEP stands for breast, uterus, bowel, bladder, lochia, episiotomy, Holman sign, emotions, and pain. The 12-point check includes the vital signs, and it goes from head to toe: breast, fundus, bladder, lochia, perineum, bowel, circulation, and pain and emotions. I typically use the 12-point check because it starts with the vital signs. Then I add the emotion with pain assessment. Remember, as a nurse, you may not be the person taking the actual vital signs. However, as a nurse, you are responsible for the analysis of those vital signs. You have to ask yourself when you assess the vital signs, are they normal for your client? Vital signs include the blood pressure, pulse, respiration, and temperature. Check your blood pressure for hypo as well as hypertension. In the pulse, remember initially bradycardia is normal as a resting pulse. The temperature oftentimes can be slightly elevated up to 100.4, and this is common during the first 24 hours, mainly due to dehydration. Therefore, if your client has a temperature of 100.4, you might want to start with hydration. Assessment of the breast includes the symmetry, shape, firmness, and tenderness. Because of milk formation in the breast, women's breasts postpartum can be lumpy. This would be normal. With the exam, milk ducts can be palpated. After delivery, the breast tissue generally is soft. By the third or fourth day, the milk has come in and the breasts are more firm. If the breasts appear large, reddened with taut, shiny skin, engorgement can be suspected. If one portion of the breast is reddened and inflamed, you can suspect mastitis. Mastitis, however, if it does occur, does not occur just after delivery but after breastfeeding is established. A woman with mastitis also has the feeling of being tired, run down, achy, has chills, or thinks she has the flu. Remember, the word mastitis means inflammation or infection of the breast. Assess the nipple for cracks or fissures. Notice on this diagram the anatomy of the breast. Cracks or fissures in the nipple can directly allow bacteria to get into the bloodstream, causing infection. However, even though the breast is inflamed, the milk is not. Note the position of the uterus as well as its firmness. If you, the examiner, are able to feel the top of the fundus, you will notice that it feels like a hard ball. The uterus is said to be firm. The uterus will often firm up by massaging the area where the top of the uterus should be located. The top picture is of the nurse using her hand to massage the top of the fundus. If the uterus cannot be felt or the fundus is soft, the uterus is described as being boggy. Lochia is described and assessed by its color, quantity, odor, and amount of clots. The diagram on the right shows the amounts. Color is rubra, meaning bright red. Serosa is a tomato red, and alba means yellow or a yellowish discharge. Lochia should not have an odor. Clots are common the first few days after delivery. After the placenta is delivered, the uterus undergoes a process called involution or shrinking. This is important because the site on the inside of the uterus where the placenta was is rich in blood vessels. Shrinking of the site reduces the amount of surface area that can bleed. Involution happens quickly. Involutional discomfort is another description for cramping. If there is abnormal involution of the placental site, it can bleed because it hasn't shrunk. It's called subinvolution. This can occur if there is infection occurring or because there is a chunk of placenta still left inside the uterus, which can separate, causing brisk bleeding. Because the uterus is held only by two lower ligaments, it can be shifted from side to side. A full bladder will cause the uterus or the fundus of the uterus to shift from one side to the other. If the uterus is shifted, its ability to contract is affected. If the uterus is not contracted, meaning not firm, it is called boggy. A boggy uterus, which is soft, allows the uterus to bleed. Remember that the side of the uterus that contains the placenta is rich in blood vessels. If the uterus is not contracted, meaning that pressure is not placed on the site, it will bleed. Although episiotomies are becoming more rare, women do tear or lacerate. Assessment of the perineum is important to assess the healing status of the skin. Women generally do not have bowel movements for the first few days following delivery. This is normal. Remember that many women had bowel movements while delivering their baby. Provide privacy, wear gloves, and visualize the site. The Rita scale is not only used in assessing perineums postpartum, but also any incisional site. Memorize it. Answer the questions as you assess. How much redness is present? How much edema? Is there any bruising and what size? Is there any discharge associated with the wound? How much and what color? And is there any odor? Are the edges of the wound approximated or is the wound open? Circulation is an important assessment. Because of the change in the clotting mechanisms, women can be prone to thrombus formation. Checking a woman's lower extremities for signs and symptoms of thrombus formation as indicated in the slide is part of the assessment. Remember the basic characteristics of pain assessment. They are location, quality, quantity, and occurrence. If you click on the link located on the slide, you will go to a website describing the FACES scale. There are several theorists who describe the psychological adjustments postpartum. One of the theorists describes something called the maternal role attainment, which is a process by which a woman learns the role of mothering, basically uses her own mother as a role model. Reva Rubin is another theorist who describes the postpartum period in 3 phases: the taking in, taking hold, and letting go. In the taking in phase, which is the first couple days following birth, the mom is very much preoccupied with her own self and her own needs. The taking hold phase begins the 2nd or 3rd day and lasts for a day or 2 as the mother now begins to assume more responsibility of her newborn and getting the newborn's needs met. Letting go is described in approximately the 5th or 6th week postpartum, in which the mother now goes back to her normal lifestyle. She includes the newborn but realizes she now has to get on with her life. Assessment of a woman's support needs and her knowledge of baby care is also important during the postpartum period. It's important for you as the nurse to know the difference between the postpartum blues versus the postpartum psychosis. Postpartum blues is normal, with expressions of sadness without reason. It generally goes away, does not interfere with activities of daily living. Oftentimes, these are the women who will watch TV and a commercial comes on and they'll just start sobbing. Psychosis requires a medical intervention. Women become so depressed that she cannot function or ignores herself and her baby. What you need to tell women is they find that their sadness and their depression interferes with them being able to get up in the morning, make dinner, care for themselves, care for their babies. They need to have medical intervention. Also remember that your discharge teaching includes the siblings, significant others, pets, and others in the household who will be directly affected by the new baby. Postpartum is also the time to remember to check for health maintenance. Does the mother need rubella? Rubella cannot be given when a woman is pregnant. Therefore, we know right after delivery for certain the woman is no longer pregnant. So vaccines such as rubella can be given. RhoGAM is also given to those women who are Rh negative, who have a baby who is Rh positive. That woman will need another dose of RhoGAM postpartum. This concludes the postpartum assessment slides. Please let me know if you have any questions. The following slides review the physiology of postpartum. The 6 weeks following delivery is referred to the postpartum period, also referred to puerperium, or the 4th trimester. Uterine involution refers to the shrinking of the uterus back to normal size. It takes approximately 6 weeks. Logia is the uterine flow consisting of blood, decidua, white blood cells, and mucus. The table on page 476 of your textbook further explains the characteristics. Notice the differences in the color. The cervix needs to heal in the postpartum period. Remember that the baby traveled through the cervix. The first 3 days, the cervix is flaccid and open about 1 to 3 centimeters. By the end of the first week, the os is closed, or about 1 centimeter. Approximately 12 weeks, the cervix resumes its normal functional anatomy. However, in the multip, it never regains the nulliparous appearance. The vaginal walls also need to heal. Immediately postpartum, they are edematous, bruised with low tone. By 3 weeks postpartum, there is a gradual reappearance of rugae, which are the wrinkles that are in the vaginal walls. By 6 weeks postpartum, the vaginal walls regain tone as estrogen stabilizes. The perineum is the area between the vaginal opening and the rectum. This area sometimes is torn during delivery. Obstetricians used to perform episiotomies, which is surgically cutting this area to allow a greater opening or passage for the baby. Episiotomies are not as common due to research showing its ineffectiveness. Lacerations may occur despite a woman even having an episiotomy. The first degree is the superficial skin layer that is torn. Oftentimes we call these skid marks. The second degree is the skin or levator muscle and vagina. The third degree laceration is the perinatal muscle and rectal tissue, and the fourth degree is a rip of the entire perineum. Cardiovascular changes occur due to the increase in blood volume. Bradycardia, or lower resting heart rate, occurs due to increased blood volume. The hematocrit rises during the postpartum period due to the increased diuresis of the woman. A woman's kidneys filter the excess blood volume after delivery, allowing increased urination. During the first few days following postpartum, the bowel is sluggish. There's increased flatulence, constipation occurs, and it's not until 8 to 14 days postpartum where normal bowel patterns resume. Remember that there is increased diuresis after delivery. However, women usually do not have the same sensation to void after delivery, therefore must be reminded. There is also an increased risk for UTI, or urinary tract infections, due to the possible trauma of the urethra and retained urine. Bladder tone is restored in approximately 5 to 7 days postpartum. Abdominal tones depends on the physical condition of the mother, the number of pregnancies she's had, and the type of amount of exercise she had prior to pregnancy. The following slides describe the changes in the breast during postpartum. When the infant begins to suckle at the breast, nerve impulses travel to the hypothalamus, which causes the anterior pituitary to secrete prolactin to increase milk production. Suckling also causes the posterior pituitary to secrete oxytocin, producing the letdown reflex, which releases milk from the breast. Oxytocin also causes the uterus to contract, which aids in involution. Following delivery, the breast secretes colostrum, which is a milk high in protein and immunobodies. Transitional milk contains protein, immunobodies, and some fat. By 2 weeks, the breast milk is at its adequate supply. By 6 weeks, the breast milk contains a higher percentage of fat. In the non-lactating woman, colostrum occurs in the first 24 hours, and then by 3 to 4 days there is engorgement, called primary engorgement, and by 4 to 7 days the engorgement begins to subside and the milk production decreases. In the non-lactating woman, estrogen and progesterone return to normal in about 3 to 5 weeks. The menses in a non-lactating woman resumes at an average of 7 to 9 weeks. In a lactating woman, the drop in progesterone stimulates prolactin. Ovulation can occur within 14 to 30 days of weaning, meaning when a woman stops breastfeeding. However, breastfeeding is not a form of contraception. Menstruation generally occurs 2 weeks after ovulation. According to your textbook, body weight returns to pre-pregnancy weight about 6 months after childbirth. This does not occur with many women. Remember that an additional child changes the family dynamics. Also, remember that cultural influences are to be considered. This ends the physiological postpartum assessment slides.